So the rationale was to investigate kind of the risk profile of our patients with language discordance. So I just wanted to get an idea of the demographics of those patients and essentially determine the risk profile in order to try and mitigate those risks later on and try to get a bit more research on the challenges language discordance has caused or causes, particularly in the oncology population. So I wanted to look at the patients with limited English proficiency because that confers a language discordance with our healthcare provider in Dublin here. And so what I did was I gathered data relating to that patient cohort from our official translator services. And I also kind of gathered information also from our social work department, just to kind of highlight the patient cohort that was relevant. And then I just collected information kind of regarding the evidence of limited English proficiency, what their preferred language is, the patterns of translator service requests, their diagnosis, treatment plan, their involvement in social work, as well as kind of GP services, like if they have a GP service, and other demographics like their age and gender, and essentially compared that to the kind of general census from 2016, just to see, was it representative? And I particularly kind of extrapolated that, looking at 3 cases in particular from different professional perspectives. So one was from from my perspective, a physician's perspective, one was from a social work perspective, and one was from a oncology liaison nurse perspective. And essentially I used those cases to kind of highlight risks that I'd know that can develop because of language discordance. And I used the formulation of the cohort, or just getting an idea of the cohort, to get an idea of the size of potential issues with language discordance. So the results from the 3 case studies showed kind of direct pathways of which language discordance can cause negative impacts or adverse patient outcomes. So from the physician's perspective, we could see that the language discordance resulted in delays in kind of treatment understanding, or delays of diagnosis and treatment plan formation. And from the the second case, which was from a medical social work perspective, the results really highlighted the so language discordance is often compounded by social issues, and that the fact that there is a subsect of these patients who have concurrent social issues. So there will be patients who they have language discordance because, and there were concurrently, asylum seekers potentially, or not need social, have kind of social determinants of health which also kind of result in adverse outcomes, and therefore that needs to be managed, and there needs to be better coordination of services for them. And the third case, really from the oncology liaison nurse perspective, which particularly looked at kind of how we deliver chemotherapies to patients, particularly in the oral chemotherapy setting, where a lot of that tends to be on the outpatient setting. That kind of determined that is not necessarily is easily transferable to the patients with language discordance. And that's particularly because in chemotherapy settings, when they're an outpatient, there's more vigilance. There needs to be more vigilance on their part to understand their the side effect profile, and to look out for things. There's just less face-to-face interaction, so there is more responsibility on the patient. And if they haven't had effective communication, if they don't understand all of the things around their medication, as well as someone who potentially their English speaking counterparts, it just puts them more at risk of adverse events with that, with medications, chemotherapies. So those 3 cases kind of highlighted specific pathways where the patients are more at risk. From looking at the database collaborated, or just looking at the database in terms of the patterns of translation services and just the demographics of our patients with language disorders, it just became quite clear that the translator services weren't very consistent in terms of the requests. A lot of the time, the patients were majority of patients had one request, which probably related to a request at the beginning of their kind of oncology journey. So when they're at their first consultation, and it maybe highlights the fact that they weren't having continual there wasn't a continual use of interpreter services in the day ward where they're getting their chemotherapy or in the outpatient setting. And that's either because it's not needed or because there's just not, there wasn't much feasibility for it in the busyness of the service. So it just kind of highlighted that there's not a consistency with the use of interpreter services with our patients, which could also lead to adverse outcomes. Another thing that was highlighted in the results, one of the main things that I found was there was a lack of documentation with regard to kind of the details of people's language discordance. So it was very difficult to identify the patients that were appropriate, or the patients who fall into that category of having language discordance, particularly if you're relying on the translator services like I was, or the requests from the translator services, so coming back retrospectively. And that just meant that there's definitely, the population of patients that I looked at were definitely underrepresented, and there would have been a lot of patients who don't necessarily utilize the official translator services, but are utilizing kind of family members and other ways of communicating. And so they wouldn't have been included in this study. And so one of the results I did find that I just felt that we need better documentation to highlight the patients, so that we can do better research, find them more for research in the future. I guess by highlighting that these patients are at risk, or just highlighting that there's a potential risk, and highlighting the pathways that patients find themselves at risk, so the pathways in which they're having inadequate communication, it can lead us to finding ways to mitigate for those risks, or finding ways to mitigate for that loss and that broken communication. And I felt that some of the ways some of the recommendations that I had from that, so for instance, the fact that it's highlighting that we have inconsistent in use of official translator services, because we've found that there's ways that we can mitigate that and ways that we can ensure that that's more consistent. Research has shown that that's the best way to communicate with our patients. It is preferred to using families and friends, and even like kind of Google devices and things like that. But it's, I guess, by knowing that we're not doing it consistently, it can lead us to kind of having actual pro formas or actual protocols in which, we have dedicated interpreter services for patients, or maybe we have them at certain intervals within their treatment, so that they're continually understanding what's happening, and their understanding is fluid with the changes in their treatment. I also thought ways of kind of ensuring better consistency with interpreter services might be like training medical staff in using interpreter services, and training them with having training sessions with interpreter services officially, and also just training staff on cultural awareness, because I think that sometimes interpreter services might not be used, or might not it might be utilized because people don't necessarily think they need it, or because patients are able to exaggerate their understanding in certain situations, and sometimes their understanding might seem a lot less than it actually is, and obviously unwitting bias comes into that, and so I do think there's a way of kind of kind of dealing with that, and that would be through the training, better training. Because I'd found that there was an issue with kind of thorough recording and analysis of kind of the relevant information for these patients. So what their what their preferred language is, and whether they need an interpreter, or those kind of issues, because it wasn't consistently documented, which meant it was hard to find these patients, which means it's hard to identify them, to do research on them, and it's also hard to identify them, and which is also the issue of identifying them. If they are at risk, we should be able to identify them better to be able to mitigate that risk. So one of the suggestions that I had in Beaumont, particularly in the hospital, was to the kind of initiation of a non-English speaking support form. So that just essentially means that when the patient enters into the service, just as you would be kind of completing a form or just completing a history, clerking them in, and some people have performers for that, some hospitals do. I wanted one which had the ability to write down whether the patient, had language discordance or limited English, and what their preferred language was. And I think if that's there, if this is in a performer, then it's more likely to be documented, and it's just easier to access. So whenever they're seen by new doctors coming through, so new SHOs, new team members, new interns, they're able to, it's easily found. So you can see straight out, okay, the patient has limited English, they're Romanian speaking. And it doesn't mitigate the need for getting an interpreter, but it just means that it's already thought about. It's already, that risk is already highlighted. The risk associated with their language discordance is highlighted. And I just think it's more likely that there will be referrals, and the appropriate actions taken to mitigate those risks will follow through. And the benefit of the non-English speaking support form, I had intended on, the plan for that is to include kind of social questions within that as well. So whether or not, the patient has a GP, if the needs for any kind of social work referrals. And the reason I wanted that on there is because not all of the patients who have limited English will require social supports, but as I've highlighted, there are a significant subgroup that definitely will. It just kind of has it all in one place, and it means the transition to outpatient care is a bit easier, and it's not as much of a burden on the social worker. And again, a small thing that we'd included in our hospital, one of the cases, one of the adverse outcomes which occurred in response to language discordance was missed appointments, because patients weren't able to, if anything in the chain of organising their outpatient chemotherapy was disrupted, if they were in the wrong place or at the wrong time, and in a busy service, them not being able to advocate for themselves, if they have very limited English at all, if they have no English at all, and they're not able to advocate for themselves, a lot of them were just kind of, it's very easy for people to be dismissed and sent away, especially if they're kind of interacting not with a doctor who knows them, or if a nurse that knows them, if they were interacting with admin who doesn't know them. So for us, what we've implemented is, what we're implementing, just simple appointment cards. The study highlighted our distribution of languages in our patient population at the present. So we have, we want to implement appointment cards that just have a basic, in English on one side displaying the appointment location, date, and hospital, like the relevant team and a contact detail for that team, or a contact detail for the ward. And then the reverse would have in the language of the patient. So it just means that they know where they are, and they can give it to whomever who can contact somebody who can advocate for them if the patient's unable to advocate for themselves. So this is a relatively cost-effective, like low-cost measure, but it's something that would directly benefit one of the cases in the report.